Hi, I'm Paul McKenna from Accel-Heal Technologies, and it's my pleasure to welcome you to today's webinar. We do appreciate you being able to take the time to join us today, especially during these exceptional times. We hope you find the session both informative but also enjoyable. There's a lot of misconceptions around the use of electrical stimulation, but today's speakers, Dr. Robert Martin and Elizabeth Ovens, will explain the scientific rationale and clinical application of electrical stimulation in wound care, as well as share some practical examples of how to use Accel-Heal in different wound types. Now, we want today to be as interactive as possible, so please do be involved and ask questions. You can do so by typing your questions in the box beneath the video and simply pressing send. And we will try our very best to answer as many today, but if not, we will certainly answer them all afterwards. Don't feel like you might miss out if you miss any of the recording. We will share the full recording next week on the Accel-Heal website. So without any further ado, I'd like to introduce our first speaker, Dr. Robert Martin. Over to you, Robin.
Hello, and welcome to today's webinar, the topic of which is the scientific rationale for electrical stimulation for wound healing. My name is Robin Martin. I'm a freelance scientific consultant, and I've been working with Accel-Heal Technologies Limited as a scientific advisor. Now, electrical stimulation for wound healing is a bit of an untold story. I've worked for 25 years in tissue repair and wound healing, and although I was aware of it, I never really paid it much attention. So I hope after today's webinar, you'll agree with me that it's actually a really interesting area and worthy of your future attention. The agenda for today is we're going to look at what role do electrical fields play in the familiar phases of wound healing, as you see on the right-hand side of the slide. What is known about the molecular mechanisms of action of the effect of electrical stimulation on wound healing, and what clinical evidence is there for electrical stimulation. Our story actually begins not in wound healing, but in developmental biology. Studies by developmental biologists have found that animals, such as frogs, for example, that can regenerate an entire limb, the patterns of cell movement and migration and differentiation are all coordinated by endogenous electric fields generated within the healing tissue. And in fact, in some experiments in the 1970s, the investigators applied an electrical stimulation device to the cut ends of adult frog limbs. Adults don't normally regenerate, but they found when the negative electrode was at the distal tip, they got a pretty good attempt at regeneration with new bone, new muscle, new nerves, whereas with the anode, the positive electrode at the tip, they really got a scrambled, disorganized tissue. So what, if that's in animals, what happens in humans? Can we see any evidence for electrical signals in human wound healing? Well, of course we can. And of particular interest to the group in the 1980s that were the authors of this paper, they showed that fingertip wounds in children, which as you may know, can actually regenerate partially, at least give you the nail back, if they're treated conservatively. And they analyzed 10 different children and looked at the fingertip injuries and showed that there was a really distinct small electrical current in the region of microamps per square centimeter of wound area, and they could be detected in the wound for several days. And it turns out that the human skin already has a stored potential for electricity, because in studies from the same group, they found that between the epidermis, the upper layer, and the lower dermal layers, there's a consistent voltage between those two layers of skin. And studies have mapped the level of voltage around the body and found on average there's about 23 millivolts, But different areas like the hands have quite a high, the palms of the hands have quite a high potential, and other areas have less. Males and females are pretty similar, and so are young and old, actually. And because this electricity is stored, it's not flowing, it's the potential, it's often referred to as the skin battery. So where does this electricity come from? Well, the skin battery is formed because the asymmetric distribution of sodium and potassium and chloride ion pumps in the different epithelial layers. You can see here in the image on the right of the screen that the chloride ions are tended to be pumped upwards, and positive ions, sodium and potassium, are pumped downwards. And what this gives you is this potential across the epidermal layer. But when there's a wound, then the current is released, and we call this the current of injury. And it's a direct current, and in the wound is a negative, and in the intact skin is the positive. And in humans, that reaches about 10 microamps after 3 hours and continue for several days. So what impact does that electrical current have on the cells at the edge of the wound? How does that affect those cells that have to go about the job of filling in the damaged tissue? Now, what we know now is that migration and proliferation at the epithelial edge are very responsive to bioelectricity. In other words, that when that current of injury starts to flow, the electricity is perceived by the cells, and a number of things start to be augmented or stimulated. And this was the work of a group in the University of Aberdeen, in Colin McCade's team in Scotland. And they looked at a corneal wound healing system. Cornea is really just a piece of transparent skin. And by adding different drugs, they could increase or decrease the activity of the sodium, potassium, and chloride ion pumps, and able to show that when you switched on the electricity, the cells divided more frequently so that they can fill the wound. When they divide, they align with the direction of the wound edge, which puts them in the right position to migrate across and fill the wound. And actually, when they migrate at a much faster speed when the current of injury is present. Now, further work from the same group actually has steadily increased our knowledge of different things which cells respond, how cells respond when they are put in the presence of a current of injury, a small direct current. And one of the things is that electric fields increase the expression of growth factors. That's quite an important discovery, because without expression of the correct receptors for growth factors, I beg your pardon, cells will be unresponsive to the signals for wound healing. So it's important that cells need the receptor, otherwise they can't interrogate and respond to the signal of growth factor. And the particular example I've picked here is the epidermal growth factor receptor. The gene expression of that receptor is increased under electrical stimulation. And if you see on the picture on the right-hand side, they used a green fluorescent dye tagged to the epidermal growth factor, and that showed where the receptor was located on the cell surface. And you can see that the growth factor receptor clusters on the side of the cell in the direction that cell migration is going to move. In other words, from plus to negative. And electrical fields can almost take control of wound healing. In scratch assays, which are often used in cell culture to investigate the response of cells to a wound, where you remove a strip of cells and then look in time-lapse video microscopy to see how the cells respond to fill the gap. In these scratch assays, if you apply the electric field in the opposite direction to that which occurs in nature, so plus in the wound and minus towards the intact skin, in the scratch assay, the cells refuse to cross the gap. In fact, they migrate in the opposite direction. So the electrical signal overrides the other signals that were telling them that they should migrate and fill the gap. And when you switch back the signal so that negative is in the wound, sure enough, the cells migrate and fill the gap. Now, this is actually quite somewhat of a classic paper. So this appeared in the top science journal, Nature. And the investigators went on to look at the molecular reasons why the electrical fields can control wound healing there. And it turns out that migration of cells in response to electric fields is controlled by phosphorylation and dephosphorylation, which is quite a well-known story now in cell growth and control. And when subjected to bioelectric fields, epithelial cells rapidly phosphorylate a protein called SARC, originally identified as an oncogene and pivotal in controlling the decision to migrate, divide, and proliferate. And they cluster that SARC protein, again, in the direction that the cells are migrating in order to heal the wound. And the authors used some fancy techniques to disrupt the phosphorylation enzymes, in this case, the PI3 kinase. And when you disrupt that, the cells cannot respond to an electric field. And when you disrupt the balancing enzyme, the phosphatase that removes the phosphate from the SARC protein, then migration was significantly increased. Now, I should point out, there are equivalent data for other cells that are involved in the healing response, inflammatory cells and endothelial cells, but we don't have time to go into those now. I guess the take-home message, though, is that endogenous bioelectricity coordinates wound healing through well-known molecular pathways. It isn't we'll apply electrical stimulation and then some mysterious process happens that we don't understand. These are nuts and bolts physiological pathways that many scientists have been studying for many years. So much for cell culture. What about human work? Because of course, if electrical stimulation can accelerate wound healing, then it may be of very use in clinical medicine, particularly looking after chronic wounds. But often when we're developing therapies, we'd like to see and test a technology on acute wounds. And one model, which is an acute wound model, which I think is contributed a lot to the field, is a punch biopsy model in human volunteers. Typically, students will come and earn a little extra cash in response for having some small 5mm diameter punches under one arm, and then similar under the other arm. And then this is a small acute wound, and then electrical stimulation devices can be applied, or sham controlled devices can be applied, and the study can be very well randomized and blinded. And each volunteer acts as their own control, balancing out any differences in wound healing potential between different individuals. And using that the technology or that methodology, the group in Manchester, Ardisha Bayat's group in the University of Manchester, for example, they were able to carry out a study and showed that many genes which are expressed in acute wounds, wound healing like that, are significantly upregulated in the electrical stimulation wounds. So look at this gene just taken as an example. Fibronectin, we know it's really important for laying down on the temporary matrix, and epithelial cells will migrate over it. In normal wound healing, this is in the controls, which obviously contains some endogenous electricity. This is before stimulation, and this is before the wound, and this is after the wound. Fibronectin gene switches on. But look, after 14 days of electrical stimulation, say 20 minutes every day for 14 days, the fibronectin gene is significantly enhanced in its expression. Similarly, there you can see there an example for collagen 4, very important for basement membrane, and also angiogenesis, the process of building new blood vessels. Without electrical stimulation, there's a modest increase, and with electrical stimulation, considerably more. And the team in Manchester were able to look at examples of genes in the inflammatory phase, proliferation, granulation phase, and remodeling phase. And if you see here, the box here really at day 14 indicates where in the healing cascade, in all the different processes, this is where the 14-day wounds in those human punch biopsy volunteers has got to. But if you give them electrical stimulation, you can see the wound is significantly advanced. It's gone further in a smaller number, in the same number of days. And they actually quantified that in a later study. And you'll probably be aware that this is quite difficult to do. Normally, acute wounds heal so well, particularly in fit, healthy students, that it's difficult to increase their healing. But sure enough, electrical stimulation in these wounds was able to make a difference that showed that electrical stimulation wounds were getting smaller, faster by day 10 and by day 14. So that's acute wounds, but of course, we are more interested in what happens to chronic wounds. Now, in chronic wounds, it's quite difficult because there have been a number of studies done. Here are 15 different randomized controlled trial studies in chronic wounds testing electrical stimulation to see if it can make the wounds close faster. One thing you'll notice is that the numbers in the two groups, 45, 15, 125, 67, the numbers are actually quite small for chronic wound clinical trials. And so what the authors here did is found a way of combining data so that they can look at a meta-analysis of these 15 studies. And some of these were foot ulcers, some of these were leg ulcers, some of these were even pressure ulcers. But they converted the results to a percentage area reduction in 4 weeks. And that gave them the ability to compare. And if you're used to looking at meta-analyses, you'll know that this is a forest plot. And here, if there's no difference between control and electrical stimulation, the studies will be lined up in the center line. If standard wound care with no stimulation is better, they'll be on this side of the line. One of the studies is. And if electrical stimulation enhances wound healing, you'll see that, as in this case, it will be on the right-hand side of the line. And this is when you pool all the data together, nearly 500 patients versus nearly 400 patients, you get quite a high statistically significant difference. So, one other thing that happens in electrical stimulation, and probably happened in many of those trials, is that a phenomenon is observed, which is that the pain in chronic wounds is often reduced. And here's just, there are a number of studies that can show this. So I'm picking just one study here. And if you look in the red box, you can see that those patients were reporting 5.3 as their pain score, 5.3 out of 10 on day 0 when the study started. And at day 3 and day 7, it was down to 2.2. And also there were signs that the number of analgesics that the patients was taking were beginning to reduce. Now, one of the explanations for pain in chronic wounds particularly is associated with the processes of inflammation. Now, in many hypotheses, chronic wounds are stuck in an inflammatory state. And then you can imagine the release of inflammatory cytokines leads to edema in the capillaries. And the capillaries are innervated with nociceptors, that's pain receptors from the peripheral nerve system. So if, as we've seen earlier, that electrical stimulation can enhance the process of wound healing, perhaps it reduces inflammation, and that's how you get reduced pain. So if we sort of summarize, we've got evidence for faster healing in acute wounds. We've got evidence for faster healing in chronic wounds, and we've got evidence for reduction in pain in chronic wounds. So if it's that good, why haven't you, those of you who are clinicians, been using electrical stimulation for many years, just like you've been using silver dressings or negative pressure wound therapy? Well, I think there are a number of reasons for that. One is that there are many different types of devices, and many of them need an experienced operator to use, know what voltages to apply. There are different waveforms, and some of them have some unpleasant side effects like muscle twitching or sort of temporary pain. Many of the devices need a clinic base or a reusable expensive console. So the patient actually has to go into a clinic to get the therapy. The scientific mechanisms are not widely understood. Myself, it wasn't until I really studied them that I really understood how detailed people's molecular understanding is of the effect of electrical stimulation on wound healing. And a really important point is that some of these systems, you have to undress the wound, take off compression bandaging, for example, or absorbative dressings, so you can give electrical stimulation, and then you have to put all those dressings back on. And of course, that can have a cost and it could be inconvenient for the patient. So I wanted to introduce to you the Accel-Heal device that is manufactured by the sponsors of this webinar today. And so this device is one of the first single-use, it's a low-voltage pulsed current device, but it's a single-use device which is pre-programmed so that we don't need an operator to use it. The patient can easily control it, and it gives an automatic preset level, and it's largely cannot be felt by the patient. It's what we call subsensory. And you can get a 12 days therapy in 6 devices which last for 2 days each. And in the second webinar today, Liz Ovens, who's got a lot of experience at using Accel-Heal with different kinds of patients, is going to give you some insights and some case studies of Accel-Heal in use. And you have to think of this, I think, as a bit like single-use negative pressure has opened up a lot more patients to get the benefits of negative pressure wound therapy. Accel-Heal has, in this device, has tried to look at the same therapy, but in a more convenient format. Accel-Heal has been tested in venous leg ulcers. We see an effect on pain. It's not a randomized trial yet, but we hope to be able to start one of those soon. And it's important that for venous leg ulcers, compression is, as we probably all agree, the best therapy for venous leg ulcers. But often, if the patient experiences a lot of pain, full compression is often not applied. If Accel-Heal really could reduce ulcer pain, it could drive greater use of compression, and that will actually give you faster wound healing, because it's really important that you apply compression and drive the edema out of the tissues. And with some colleagues, we hope to start an RCT, a pilot RCT on that later this year. Now, one experiment which I'd just like to tell you about as we come close to the end is a study which might give us some insight into why we see reduction in pain in chronic wounds. This again was a study in volunteers, But this time, they didn't have a biopsy, they didn't have a wound. The Accel-Heal was applied to healthy, intact skin. And after 48 hours of electrical stimulation therapy, biopsies were then removed, and gene expression was compared in the areas of skin that had the placebo device compared with areas of skin that had the active Accel-Heal electrical therapy. And there were about 30 genes, which were the ones which showed major changes in gene expression, between 3.5 and 2.5 fold. And some of the genes were very notable because they're known markers of inflammation. So the S100, A7, A8, and A9, and the SERPIN-B4 genes are well-known markers of inflammation. And indeed, a study in venous leg ulcers a few years ago by Gotto et al. Showed that in venous leg ulcers, the level of S100 in the ulcer exudate, the exudate from the wounds, actually correlates with the intensity of pain expressed by the patients. So you see here in the study, here on the x-axis is the concentration of S100, and this is the pain intensity reported by those different patients, in all 22 patients. And the two axes are correlated and statistically significant. So it may be that as electrical stimulation attenuates inflammation, maybe this is a reason why the pain is reduced. However, but we can't rule out that there might be direct effects on nociception. And in other branches of medicine, much research is going on in uncovering close associations between nervous and immune systems, and some of these have been using electrical devices as well. So, as we come to the end, there are still a number of questions that need to be asked about electrical stimulation. We don't really know exactly how a cell senses the electrical field in the first instance. We know how the cell responds to electric fields, largely through protein phosphorylation. But the initial response may be involving voltage-gated ion channels. I guess it's really a hypothesis that in chronic wounds, chronic non-healing wounds, the original electric field, which must have occurred when the wound was fresh, has long since dissipated. But actually, that's not been proved in clinical studies with measurements in patients' wounds. Still unknown is what happens after surgical debridement. If you debride a wound aggressively, could this regenerate an electrical bioelectric response again? And could that be one of the reasons why debridement is often beneficial for wound healing? We don't know. There is still no consensus on what the best pattern or dose of electricity is, although since many different types of device work, you have to ask the question, maybe does it matter? Is activation of wound healing cells sufficient to boost the wound healing capability of tissue? And do we actually need the directional guidance? Does a negative always have to face into the wound, or is stimulation of wound healing sufficiently achieved just by activating the wounds by bioelectricity? So to summarize, we've shown that in vitro studies, bioelectric signals activate immune cell function, angiogenesis, granulation, and they initiate keratinocyte migration and proliferation. Clinical studies show giving exogenous bioelectric fields to acute wounds accelerates acute wound healing. Those are in the volunteer punch biopsy studies. Clinical trials on chronic wounds support the application of bioelectricity to reactivate stalled phases of wound healing. But I think everybody would agree that larger, better trials would be needed. And electrical stimulation appears to reduce pain, although it's not yet certain if that's indirect through reduced inflammation, or direct through a nervous immune system interaction. So I'll finish there. If you have any questions, please be sure to email them in, and we can take them at the end of the next presentation. Thank you very much.
Thanks, Robin, for that very detailed presentation and highlighting the amount of evidence that supports the use of electrical stimulation in wound care. Please remember to fire any questions to Robin and we can answer those at the end. And it's now my great pleasure to introduce the second speaker, Liz Ovens. Liz is a very experienced tissue viability nurse who will share her experience of using electrical stimulation therapy in hard-to-heal wounds.
Hello, thank you for joining the webinar today. My name is Liz Ovens and I'm an independent tissue viability specialist nurse. I've been using Accel-Heal in clinical practice for approximately 8 years now. So I'm going to talk to you today about the current evidence for Accel-Heal, how to apply it in clinical practice, the benefits to both patients and clinicians, and I'll finish off with some case studies. So as Robin has discussed, Accel-Heal is a one-off 12-day electrical stimulation therapy comprising of 6 single-power battery units. Each unit delivers an automated program of subsensory electrical pulses over 48 hours, and it's designed to stimulate wound healing and also reduce pain. And it can be used alongside your standard therapy or moist wound healing, as long as compression therapy. As I say, I have many years of experience using therapy, and I've used it on a variety of wounds, ranging from leg ulcers, venous leg ulcers, arterial ulcers and rheumatoid ulcers, abdominal surgical site wounds, and pressure ulcers. And the results I've seen are really consistent with what is demonstrated in the clinical evidence, which I will show you in the next slide. I would estimate approximately 90% of my patients have benefited from the therapy, ranging from complete healing to reduction in wound size, reduction in exudate, and very importantly, reduction in pain. So Robin has outlined the wealth of evidence surrounding electrical stimulation in this technology area. And in addition to this background evidence, Accel-Heal also has significant specific evidence developing to reinforce its efficacy. So there's been a range of studies undertaken across both the UK and Republic of Ireland. And these include 23 published papers, 10 papers and 13 posters. And as you can see, there's a range of evidence there: scientific papers, economic papers, clinical papers, and case study papers. One of the economic papers was a recent study by Posner et al., and this has been accepted for poster presentation at UMA this year. And this discusses analysis of an RCT using Accel-Heal versus a placebo for 100 patients with VLUs. The study determined time to healing was almost 4 weeks shorter than in the Accel-Heal group than the placebo group. And due to the faster healing, the paper also demonstrated an overall cost in healing of the venous leg ulcer with a saving of £78 per patient. And there was also a saving of 122 weeks of nurse and GP resource calculated for every 100 patients that were treated. All the papers have demonstrated consistently improved outcomes and consistent health economic benefits. I'll demonstrate some of the improved outcomes in the next slide. Many studies have been undertaken in a range of wounds, but a large proportion of them have been on venous leg ulcers. A recent study, again recently accepted for UMA this year, undertaken in Ireland, and this was a single centre prospective study undertaken between September 2018 and February 2019 for 6 months. And all consenting patients attending the vascular outpatients clinic with a foot ulcer and in whom placement of the electrical pads was possible were eligible for inclusion. Patients with electromedical implants, with cancer, or who were pregnant, or who were sensitive to adhesives were excluded. By the end of the 12-day treatment period, there were reductions in size noted in 7 of the 8 patients, with an average of 42% reduction. 6 out of 8 patients expressed satisfaction with their treatment and with the progress during the evaluation. 2 patients were lost to follow-up, and of the 6 remaining patients, 3 patients were healed within the study period. So progress towards healing was seen in most patients over the 12-day period, which then continued throughout the study period. So this slide is demonstrating data pulled from evaluations undertaken in 4 UK centres on 51 patients with venous leg ulcers. And these patients had all previously been having compression therapy, but had no response to this. It demonstrates a significant reduction in wound size over the 20-week period, with a 91% reduction in wound size noted at 12 weeks, when 50% of them were noted to be healed. And by the 20-week period, just under 83% of those wounds were healed. Anecdotally, I've also noted that venous leg ulcers have a reduced risk of recurrence. Patients have reported a difference in the healing of tissue. Another patient reported to me that they could have a hot shower where previously they'd had to endure warm water during showering. And this obviously requires further research. Excuse me. As mentioned by Robin, there was a reduction in pain noted for the 51 patients, which reduced by 63% over the 2-week period. And indeed, I've also noticed this in clinical practice really within a few days. And in fact, I've even had reports of improved pain within a few hours of starting the therapy. So Accel-Heal has been demonstrated to relieve wound pain and stimulate healing. And this, of course, improves quality of life for our patients. It is a safe treatment to use in a wide variety of wounds with only a few contraindications, and all the information on this can be found on the website. Cost effectiveness has been demonstrated in the economic papers, and this is really demonstrated as wounds begin to heal with less exudate and therefore requiring less dressing changes and less reducing the nursing and medical time. And this relief pain has led many patients to reduce their pain medication, tramadol, opiates, for example, return to work and resume some sort of normal social activities. It has also enabled tolerance to investigations, vascular studies, for example, and to allow them to tolerate compression therapy, including full compression. And of course, by reducing pain, it further improves mobility, which enhances the blood supply to the wound, which further enables the wound to heal. So the therapy is very easy to use. You simply clean the surrounding peri-wound with an alcohol wipe. Ensure you don't use any emollients prior to application of the electrode pads. And these 2 electrode pads are placed either side of the wound opposite each other, approximately 1 to 2 centimetres from the wound edges. The electrode wires are then threaded through to the compression bandages on the outside layer, and then you simply attach the device to the electrode pads wires. The electrode pads can be changed every week or more often if clinically indicated, if there's, for example, excessive exudate, and the device is changed every 48 hours by either the patient, carer or clinician attending. So the treatment consists of bursts of varying electrical stimulation delivered within the optimum range, and this is separated by a phase of very low stimulation or rest period. It provides a pulse current stimulation, which has been shown to be more effective than other types of stimulation. So the therapy is completed following 12 days. And during this time, as highlighted by Robin, we would expect to see a reduction in inflammation and certainly in the pain, and kickstart process in the healing process. So typically you will notice a change in the peri-wound skin with less inflammation, less exudate, which will further improve the peri-wound tissue, and a general cleaning up of the wound bed, such as reduced slough. So the therapy is not designed to heal the wound within the 12 days, but it will help to kickstart the wound, reduce the inflammation and reduce the pain, while standard therapy continues following the therapy. And hopefully the wound will then follow its normal healing trajectory. As mentioned, there is a wealth of evidence for Accel-Heal which can be found on the website. So I'm just going to show you now a couple of my case studies demonstrating its use in clinical practice. So my first patient is a 50-year-old female with recurrent venous leg ulcers to her right medial malleolus, which had been present for 3 weeks. She had a previous fracture to her right ankle and significantly reduced ankle flexion, which obviously increased the risk of recurrence to these wounds. She'd had several courses of antibiotics with no real benefits and no improvement noted to the wound. She had a very high pain score of 10 out of 10 and was really intolerant of dressing changes, and I was very challenged to be able to take a wound swab during this first assessment. She was unable to tolerate a full Doppler assessment, but her pulses were trying biphasic sounds, and she was unable to tolerate any compression therapy. Her wounds measured approximately 7.5 centimetres square and with 0.5 centimetre depth and an area of slough in the middle of 10%. She was having a dressing regime of antimicrobial cleansers and dressings and support bandages. So we commenced the therapy that same day with the aim to reduce the inflammation and, very importantly, the pain, in order to facilitate use of high compression therapy. As you can see, the electrode pads are in situ there, about 1 centimetre from the wound edges. The patient was taught how to apply change the electrode device herself, and we continued with twice weekly dressings. And just 5 days following the therapy, her pain was reduced from 10 out of 10 to 3 out of 10, and she reported improved sleeping and tolerated the dressings very well. And the wound was noted to be 100% granulation at this point. The pain continued to improve with reduction in wound size, and as you can see there, by the 9th of January, there is a significant improvement, and Doppler assessment was undertaken, and we then commenced some high compression therapy in view of her risk of recurrence before we measured her for compression hosiery. And the wound went on to fully heal by the early February, and she reported how delighted she was with this wound healing, where previous ulcers had taken over 6 months to heal. So my second patient is a 75-year-old female with recurrent foot ulcers to the dorsum of the right foot, which have been present for 4 months. And she'd been previously managed and cared for by her podiatrist brother. She did have some non-concordance issues relating to analgesia and various treatment options. She did have signs of arterial disease with clawed toes, poor mobility, and a vascular assessment determined that she had significant stenosis in the superficial femoral artery, and she was added to the waiting list for an angioplasty. She had a very high pain score of 8 out of 10 and had 2 wounds measuring approximately 6 centimetres square with 100% devitalised tissue, yellow slough. And you can see quite rolled edges, none advancing with punched out wound. And she also had presence of keloid scarring. She initially declined using Accel-Heal therapy due to other health conditions, and we decided to use some gel dressings in order to reduce the pain and try to debride the wound. She was intolerant of any form of surgical debridement. This initially reduced her pain to 4 out of 10, but then this quickly increased again to 8 out of 10. So we did commence the therapy in May. The wound dimensions were unchanged and the pain score was still 8 out of 10. And within 5 days of commencing the therapy, the wound was significantly improved. As you can see on the top photo, the pain score was reduced to 0 out of 10. And by the end of the 2 weeks therapy, the wound was really advancing very well. And the wound went on to complete closure by the end of July, and she went on to then have her angioplasty the following month. So just to finish off, there's a wealth of evidence for electrical stimulation and Accel-Heal therapy, and this is available on the Accel-Heal website. Accel-Heal provides a targeted early relief of pain, as well as stimulating the healing process. And this obviously improves patients' mood, improves their patients' quality of life, improving mobility, allowing them to have social activities again. And it also allows tolerance of other gold standard treatments such as compression therapy, and also can be alongside other advanced therapies such as topical negative pressure. It is a 12-day one-off therapy used alongside current topical treatment. It is very simple to use, both for clinicians, carers and patients themselves. And it is a one-off, off-the-shelf, no expensive kit or large consumables needed, and very little training required. And cost effectiveness has been demonstrated in reduction of dressings used and nursing and medical time. Thank you for your time.
Thanks very much, Liz, for your presentation and sharing the clinical outcomes that you've achieved when using Accel-Heal. I'm sure people have many questions to ask you. And on that note, we're now moving to the Q&A session, where we will try to answer as many questions as we can. Thanks very much.
Well, we've certainly had a lot of questions, and there is a common theme amongst lots of them. So I think we'll start with those where we have a common theme. And the first question I have is, do you have to use Accel-Heal therapy for the full 12 days? That might be best for Robin.
Okay, Paul, thank you for that. 12 days therapy. I think the company have accumulated most experience with using 12 days therapy. And when you think about the job you're asking the therapy to do, you're asking it to reactivate a stalled wound. And then you need to allow that those biological processes that you've set in motion sufficient time to run their course, maybe move inflammation, through those processes and then begin to see changes in the wound. It comes as a 12-day therapy, so in a sense, there's no merit in reducing the number of days because the cost is the same. So I think that would be the position that we would take on that.
Okay, thanks, Robin. Mine, Liz, and we'll go back to a couple of clinical questions that we've received. And one in particular that's recurring is for diabetic foot ulcers. Do you have any application tips when using Accel-Heal?
Well, most of my experience is actually in using the therapy on patients for diabetic foot ulcers. And of course, it is challenging with these wounds. There is actually some evidence available which actually illustrates that the signals do actually travel quite a good distance. I do actually have a photo to show you. This is actually a patient who had vasculitis, diabetic as well. As you can see, he's got quite extensive wounds on the dorsum of the foot, and they sort of went through to the toes underneath the sole of the foot. He had a very high pain score. We used the therapy with the aim to reduce the inflammation and the pain, in order for him to be able to go back to work, because he was quite a young gentleman. So you can see where I've managed to place the electrode pads sort of not really in the normal position that I would have wanted. I would have normally applied them sort of a bit more in line with the middle of the wound, but we did actually have very good results with this gentleman. His pain score reduced from 10 out of 10 to very, very low pain, and managed to get back to work, which was really our aim. But it actually, amazingly, we actually noted quite considerable improvements to the wound bed as well, which we hadn't really been expecting. Unfortunately, we lost him to follow up, so I haven't actually got any post-therapy photos to show you. So yes, obviously it is challenging, but as I say, you can sometimes, maneuver the pads slightly different areas. Again, another challenging area would be on the sole of the foot, particularly if the patient's still mobilizing. So it may be recommended to have a little bit of a period of rest or non-weight bearing during the therapy to sort of reduce any risk of pressure from the pads. I hope that.
Thanks very much. With the coronavirus outbreak, we've had a lot of questions around that and the need for patients to self-care. A lot of people have asked, is the device easy to use and suitable for use by patients? Perhaps Liz, if you could answer that one.
Yes, it's a simple answer. It's very, very easy to use. And we educate patients, obviously, about the therapy in order to get them to sort of be involved in it. And certainly, my experience is the fact that they do usually change the device after the 48 hours. They feel like they are part of that involvement, which has been really beneficial. So and we do know there has been studies where patients actually have improved outcomes as a result of being self-treating. So very easy for patients to use. Absolutely.
Okay, we've also had a number of questions received about the use of Accel-Heal before compression therapy. Do you have any experience of that?
We've used it actually specifically to enable us to apply compression therapy. This is a big challenge, I'm sure many people can identify with. Many patients can't tolerate any compression, or certainly high compression, the gold standard high compression. So we've frequently used Accel-Heal in order to facilitate that. And then obviously once the pain's resolved, then we can go on to use the compression therapy as indicated. Often I've seen the wound actually improving amazingly even before you can commence the compression therapy, but obviously then we can commence the compression therapy following the Accel-Heal. So there has been a few centres actually in the UK that have actually set up pathways specifically for that within their leg ulcer pathway. So they've got guidance as to how they can use the therapy in order to facilitate the compression therapy. But I think, as Robin highlighted, there is going to be a study done later on in the year specifically looking at this in terms of pain reduction to facilitate compression therapy. So yeah, good question.
Yeah, it is. Thanks, Liz. Then Robin, this one might be for you. What is the program of electrical stimulation delivered by Accel-Heal?
Right, so Accel-Heal is classified as a low voltage, biphasic, monophasic, pulsed current device. So that's quite complicated, but I'll explain what that means. Every 2 hours, Accel-Heal runs a program for 30 minutes, and it has a mixture of biphasic. In other words, the electric current goes from baseline, positive and then negative, and then positive and then negative. So that's a biphasic period. And then there's a monophasic period where it just goes from baseline to positive and then back to baseline. And those are arranged within the 30 minutes, 7 minutes of biphasic, followed by 20 minutes of monophasic, and finally 2 minutes of biphasic. And the idea around this was to essentially expose the tissue to really all sorts of combinations of frequency and current levels. I guess it seems to work, but it's a low voltage, and as I've said in the answer to a previous question, the low voltage is responsible for the fact that it's subsensate and will never make your muscles twitch. So I think if that's a somewhat complicated answer, but that's the type of device it is: low voltage, biphasic, monophasic, pulsed current.
Okay. Next question was about the use of Accel-Heal with other types of products. Can you use Accel-Heal with negative pressure wound therapy? Perhaps Liz for this one.
Mm-hmm. Yeah. Yes, indeed you can. You can use it with most other standard, both moist wound healing therapies and other advanced therapies. The only treatment I would perhaps be a bit cautious with, or perhaps delay, would be use of larvae therapy, because with the secretions from the larvae, when you're trying to protect the peri-wound skin, it may be a bit of a challenge with the electrode pads, but certainly other therapies, being negative pressure being one of them, they work alongside very well. And in fact, the Accel-Heal facilitates the application of the negative pressure often, because a lot of patients are not tolerant of negative pressure, particularly venous leg ulcer patients. And so actually applying the Accel-Heal can sometimes facilitate the ongoing need for negative pressure if it was indicated. Often as well, the therapies, Accel-Heal therapies, work so well that you perhaps don't even need to apply the negative pressure afterwards. But yeah, you can use them together.
Okay, thanks, Liz. And another question for you: how soon have you noticed changes to the wound bed and pain after therapy has started?
I think I've probably covered the pain aspect in one of the previous questions. In regard with the wound bed, I would say by the first dressing change, I've noticed changes. So sort of 2 to 3 days of starting the therapy. Typically a change in the peri-wound tissue and the wound bed itself can look generally much cleaner looking, less slough, some nice healthy granulation tissue, and that then continues to progress. Some patients are a bit slower in that than others, but certainly by the end of the 12 days, you'd certainly start to be seeing some changes in that wound bed in the majority of the patients that I've seen.
Okay, thanks, Liz. And Liz, have you had any issues or adverse events with the use of the electrode pads?
Not myself, no. I've had a few patients I've been very cautious regarding these pads because of previous allergies to adhesives, but didn't really experience any problems. I do tend to err on the side of caution and change the dressing perhaps a bit more frequently in those patients. So I perhaps would change the dressing after the first sort of 3 days rather than leave it for a week, just to check that they're all as well under the pads. But no, I've not had any adverse events at all with the electrode pads. You also have to be aware if there's a lot of exudate to perhaps apply the dressings a bit more frequently as well.
Okay. Next question we've had, it's around supporting patients. Are there any resources to explain the therapy to patients?
Yes, there's patient information advice on the website, quite easy to read and see for patients. And we would also go through that information with them as well for those patients who wouldn't have access to online information. So yeah, there's plenty of information available for them on there.
Yeah, okay, thanks, Liz. And another question that we received also regards to negative pressure, that you sometimes see a visible response to the healing. Do you ever see this with Accel-Heal?
As mentioned in the previous question, I think, yes, you can see a definite response when you first start the therapy in most patients. Some wounds can be a little bit slower. We know obviously the more chronic wounds may be a bit slower in having these changes, and also larger wounds maybe takes a bit longer for the wound contraction to begin. But yeah, certainly from my experience, I've seen changes fairly soon after commencing the therapy in most of the patients, and certainly in the early days, even if it's slow, there are some subtle signs of change noted during the therapy.
Thanks, Liz. And this will be the last one for today. How far does the electric energy penetrate into the deeper dermal tissue, Robin?
Oh, well, that's a really good question, and one which is actually quite difficult to investigate. But all I can say is that Accel-Heal technologies have done some bench work with a model that used different slabs of gelatin. So, you know, gelatin essentially a sort of a collagen solution, and quite a dense collagen solution. And they positioned the electrodes, you know, around, so that they could add another slab, another slab, another slab. And eventually it was demonstrated that you could still detect the signal 6 centimeters through a big multiple slabs of gelatin. So I guess that's, I mean, that's not clinical work exactly, but it is, you know, a good indication that the signal extends pretty far, I think. In particular, in those examples that Liz was showing of the diabetic feet, you find that the signal, you know, really travels quite a long way around a foot. You know, and he may even have, the way Liz positioned those electrodes, she may even have got some signal on the plantar surface. So I think it's you can be pretty confident that the signal goes quite deep.
Well, thanks very much for joining today. If we didn't answer your question, what we will try to do is make sure that they're all answered on the website, and the recording of today and the live Q&A will also be available. Thanks again.